Hello, and welcome to the Feeding Pod. This is your host. I'm Brianna Millick, and I am a speech language pathologist and certified lactation counselor. I specialize in infant and medically complex feeding and primarily see patients in the home health setting, although I do have some that I see in outpatient or via telepractice. I'm also an instructor at the university level and a PhD student studying communication and information sciences. I have a huge passion for evidence-based practice and supporting information literacy in speech, language, hearing, feeding, swallowing sciences, specifically as it pertains to social media and translational research. This podcast is meant to share anything and everything related to being a pediatric feeding SLP, feeding therapist, with sprinkling in a little bit about working in academia, being a PhD student, and how to access, appraise, and implement research into clinical practice. Some episodes may contain guests, and I'm already looking forward to some of those coming up, while others might just be me rambling about something that's been on my mind. Regardless, my goal with this podcast is that you walk away not just with newfound knowledge, but with the inspiration to think critically and not be afraid of research. So without further ado, let's get into today's episode.
Welcome back to the Feeding Pod. This is Bree, and I'm just going to apologize in advance for my extremely stuffy nose and my hyponasality. It's just going to be part of it today, and we're just going to deal with it together. I am back with Tova Fian today, and we're going to basically go through a part 2 of our critical thinking with pediatric dysphagia and talk about what you can do to support your critical thinking skills. What is implementation science? How can we support information literacy, especially in this age of everything being fast and quick and digital and social media and online, and really trying to bridge that gap to support clinicians in evidence-based practice, and which in turn supports our families and our clients. So Tova, how are you? Welcome back.
Hi, thank you.
I'm so happy to have you back here and for us to get into all of this stuff. So
Me too.
So Tova, if you will, kind of give us an idea. You took us through like your progression of like building your critical thinking skills as a clinician, your experiences, but give us an idea of like, where are you at now? What are you doing now as a speech language pathologist? Like, tell me more.
Okay. Isn't it weird to talk about yourself? So I'm a speech language pathologist, I'm a certified lactation counselor, and I left after many years at a children's hospital to start a private practice where I specialize in feeding challenges of all varieties, mostly infants and toddlers, and I see a little bit of early language too. And those are really my passions. And I love so much just partnering with families and partnering with other providers to put together the pieces of the puzzle for each kid. And I teach dysphagia for Widener University, which is an awesome program. And they've been so open as far as critical thinking, like adapting and growing and changing to meet the needs of the students. Should I talk about Get Cafe?
I was about to say, there's a little bit more. It's a little bit more to you.
Yeah, so there's a place called Get Cafe in Narberth, Pennsylvania. I should say where I'm in South Jersey, outside of Philadelphia. But there is a cafe that my husband and I were able to help start probably about 10 years ago with some amazing people. And it was a family that I met working in early intervention, actually, and their son has trisomy 21, and they wanted to start a business that would employ adults with disabilities. And so it's grown a lot. And now there's maybe between 40 and 50 adults that work there. And it's just an amazing place. Like, you leave and your face hurts because you're just so happy. And I've learned a lot because most of my experience has been in pediatrics. So to see adults and challenges they face, or fears or problems that their parents have, and also to see their victories, and the things they enjoy and the friends they make and all of that stuff. It definitely gives a broader perspective and informs me even working with them at a different age.
Wow. Yeah. I think that's, even just like that experience alone probably did help in turn with some of your critical thinking, especially like I'm thinking about like goals. And when we're writing goals, like even early
Oh
on,
my God,
we need
yeah.
to be thinking like long-term, why does this matter? And so much of that is like, I mean, parents think about their child as an adolescent and as an adult so early on, and being able to like help them with that conversation and through it all. So that's very cool. If I'm ever in the, North Jersey, is that what you said? East,
So
North?
I'm in South Jersey outside of
Wow.
Philadelphia.
Okay.
Yeah. So that's where my office is, Pediatric Feeding Partners. And then the cafe is called Get Cafe, and that's in Narberth, Pennsylvania. Widener University is also in PA, in Chester.
Okay. Okay. Well, we have that Pennsylvania connection because I teach
Yeah.
at Pennsylvania Western University, and
Oh.
I also can harp on that school being very amazing in, talking about like they now have a course, which is one of the courses that I teach on information literacy and CSD, and being able to like talk through all of that and how that applies to our patients. So I love to see that. I love to see universities making that push toward it. So awesome.
Yeah, for sure. And what you said about goals resonates a lot too, because it really shifted how I think about even neurodiverse affirming practices and how much I had to learn. Just seeing the goals, quote unquote, that they needed is mostly like self-advocacy and finding people who had shared interests with them that they could be friends with or create relationships with was really what was valuable to a lot of the employees there who wanted to work on different things.
Yeah. And I think sometimes we forget that those are skills we can work on early on. Like even when we are working in that early intervention or birth to 3 or like, early school age, like we should be targeting that even then. So
Yeah.
very cool. Very cool.
Yeah.
Well, thank you. Real quick, if somebody wants to, I'm going to ask you this again at the end of the episode, but
Oh,
if somebody wants to contact you or find you, like, are there ways that people can, see your clinic and what you're doing?
yes. So my website is pediatricfeedingpartners.com. And then I'm on Instagram at Pediatric Feeding Partners. Those are probably the easiest ways to reach me.
Perfect. Yeah, that sounds great. And I'll make sure to put that in the description for anybody that's looking for it. So if you have extra questions or if you're in the area and need some services, then you can reach out to Tova. Okay. So let's shift now. Let's shift into talking about how to build critical thinking skills. So now we're talking about like, right, you can learn to be a critical thinker, but you do have to be an active participant in this process. You have to acknowledge like this is something ongoing. So let's talk about this. Let's talk about them.
I have a dear friend who would tell me that I think she actually she accidentally DM'd you. She meant to message me.
Oh, yes, she did.
So she talks about
and then we started talking.
Oh, she's amazing. So this dear friend, mentor, she would talk about how like you have to make your own pearls in this field. Like there's so much that we can accomplish, that we can contribute to our field of speech language pathology, but it's really about like making those pearls for ourselves. And I just love that analogy so much.
No, I love that because she texted me or DM'd me and said like big pearls. And I was like, I don't know what that means.
I love it. I love her so much. But yeah, I think that's part of it too, is like we can always find reasons why things are hard. And I know like our jobs can be hard and there can be like burnout and overwhelm and like feel overworked, but also trying to find ways to build in those opportunities for yourself to keep growing. Because I think if you can do that and find ways to be excited about your job, that it really helps with that feeling of burnout and or like looking like maybe you're not in the right setting or the right thing. Like if you're miserable all the time and you're kind of stuck, like, I don't know, do something else. There's so many things you can do in our field or like literally do something else entirely. But
no, I agree with that. That's thinking about like the, and I know we're going to talk a little bit about these, not as much, but like the sunk cost fallacy. Like just because you've spent a lot of, do you know this fallacy? Okay. So the sunk cost fallacy is basically like this bias we have to continue on a path because we have spent time, energy, and money on something. When the rational thing to do would be, hey, this isn't working, or hey, I don't like this, I'm going to walk away. But sunk cost fallacy is where we're like, oh, I already did so much for it. I think that I should like, so if you're in a situation, right, like you're like, I am working in blank setting and I'm miserable, but I've been here for 10 years. Do I really want to like, step away? It's like, yeah, step away if you're miserable. Like if you are not happy, be gone. We have so many options in this field. And that's really hard though. That's a cognitive bias. That's hard. I totally empathize with that. It's really hard. Or if you spent thousands of dollars on certain like certifications or, intervention methods, and you're like, wait, this doesn't actually work the way I thought it would. Like, it's okay to pivot, but it's hard to do.
I my practice is always growing and changing. And there are things even that I was recommending like a few months ago. There's like one thing in particular where now I'm just like, oh shoot, like, no, it wasn't. Yeah, we're gonna put that away now. So I think like being okay with making mistakes is actually a really big part of critical thinking. And I try to model that for the students that I teach too, because I definitely make a lot of mistakes. Even as a professor, like the way that I might think I'm communicating information really clearly, and then I can tell based on the feedback that I get that like it wasn't, so owning that, or owning if I like post something wrong or I like grade something wrong, like if we can model like, yeah, I made a mistake, I'm learning, I'm figuring this out, it makes it okay for other people to feel open to make mistakes and to ask questions, as opposed to like, I am so confident and 100% right all the time. That's also a red flag for me. When people like have all the answers and know all the things all the time, I'm like, I don't know about that.
Yeah, no, I agree. And I think like recognizing that like it is okay to be like, I'm not 100% sure about that, but like I'll do my best to find out. Like I will start. Someone messaged me and I have a post I'm going to create about this coming up. It'll probably be out by the time this podcast episode comes out, but someone messaged me and was like, what's the research actually say about meal times having to be under 30 minutes? Like we all say that, but like, do we actually have, and it's like one of this, and I literally messaged them and I was like, okay, here's what I found. And I like pulled up all this stuff and I'm like, but literally thank you so much, because I just went down like the deepest rabbit hole, because that is one example of something that I'm just have always said. And like, is that one necessarily like, thinking risk of it, is it that bad or that big of a deal? Maybe not, but also like you have to recognize when something maybe isn't exactly as it seems, right? So like we have sometimes standards or things, but like it literally happened like 2 days ago. And I went on this like deep hole trying to figure out like there was just so many like anecdotes on mealtime should be under 30 minutes, but like, because why? Like what are actual mealtime averages? How long do mealtimes actually last for majority of people? And I just thought that was so interesting.
Yeah, it is really interesting. And it's one of those things like teaching has made me such a much better clinician, because when it comes to that why, I have to understand what the research says about it and what my rationale is for whatever I'm teaching. So it's making me question myself, like, wait, why do I do that? I haven't thought about that in a while. And like figuring out, it's hard for us to find in ourselves those places we're on autopilot, because we're on autopilot. I think it maybe takes, I don't know, what does it take? Slowing down or
Slowing down, I think, is huge with critical thinking. I talk to my students about that in information literacy class all the time. I go, majority of the time, what's rational, what makes sense, like, what the red flags are. But if you are on that fast autopilot, just scroll, quick Google search, click a link, and just like, you don't slow down for a moment, you're going to forget, because part of like cognitive biases is heuristics, which is those mental shortcuts. Your brain wants to go the fastest way possible to make a decision.
I want to tell you that a lot of times when you're talking or when I read your posts, I have to Google things because you use these words and I'm like, oh yeah, it's really interesting. I'm gonna go see it.
You're like, actually, I have a podcast episode coming up that's going to be on a bunch of different logical fallacies and cognitive biases, and we're going to like go through specific examples in the feeding and nutrition world. I'm so excited. It's with Dr. Steph Compton. She's a PhD in the like nutrition science world, and I'm so excited about it. But yeah, but like, I mean, our brain wants to go with the path that's easiest, but sometimes we have to slow down to make it go on that other path to say, wait a minute, is this actually something else that you said that I wanted to reflect on a little bit is, you talked about how like teaching has helped you so much with like questioning why and reflecting on your practice. And I definitely want to encourage people, like one way to improve your critical thinking isn't necessarily through like teaching a class at a university, but like even supervising and mentoring is
Yeah, for sure.
for that. Like, I think any interaction you have with clinicians where you are providing that type of relationship, like you're in a mentor mentee role, I think
Yeah.
refines that a lot.
And I think the flip side too, like what I'm hoping is that the students that I have, I'll tell them, like, you might go out to a placement and your supervisor is going to ask you to do something, or you might see something that's very different than what we talked about in class. So look to like, I'm not God. I'm just giving you the best information that I know, but like, see for yourself, ask questions, like look into the resources that they have, but setting them up so that from the outset, it's not like, oh, my supervisor is like the authority on this. Like, we're figuring this out together and our field is always changing. So, as a student or a young clinician, you might be able to teach your supervisor or your colleagues something.
Yeah, absolutely. I think that's a big one. And so that we're like, our role as instructors or supervisors should also be to incite that type of questioning and learning so that like our students and our student clinicians do the same thing. Like anytime I've worked with a student or a student clinician, I'm always like, please literally always ask me why. Even for something small. If you're like, yeah, I don't think that really matters, ask it. Like,
I thought it was gonna be something with your hair because you just moved a hair. So I thought
I just moved the hair. No, it's just in my face. It's like just ask it or say like, hey, Bree, I thought that approach was interesting. Why did you implement it? And like, where can I read more about it?
Mm-hmm.
Where can I learn more about like how you applied that or why? And kind of like expanding off of that too, because I hope that students take that into, like you said, all the other settings. Because again, I don't know everything. I'm this much of the like all the things there is to
I'll give you like a few more inches. She just like gestured like a half an inch of knowledge.
Yeah. So. But there's so many different settings. And even if I'm doing home health in South Carolina, that looks different than home health in New York City and home health in Texas and California, so even within that, everyone's going to bring different experiences. And so recognizing that of like so many people bring other things to the table, but that open discussion I think is important. I want to shift a little bit because I want to hear you talk about how you navigate thinking critically, especially if it's something that you disagree with. So maybe someone is providing an approach and you're like, that's weird. I don't really agree with how they're applying that. Or like, is it that I disagree or is it that I don't understand it? Or like, how would you approach that type of situation with a colleague, whether it's someone you're working with or like, maybe it's I'm thinking about, I feel like a lot of times we overlap with like occupational therapists. I get this question a lot, like the OT's doing this thing and I don't totally agree with how they're approaching, this situation. Like, how might you start that conversation or what might that look like?
I have a good example of that and I hope I don't butcher it because it was a while ago, but I think, okay, so first the answer to the question is if my guard goes up or I don't agree, then I want to ask questions instead of coming at it from a place of judgment. I want to come at it from a place of curiosity because I definitely don't know all the things and I don't know for sure all the other like perspectives and disciplines and specialists. So an example would be GI. So there was a baby, I don't even remember who this patient was, but I just remember the situation where the baby was on reflux medication and the parent was asking about Enfamil AR, which is like a formula that's often used for reflux and it thickens when it mixes with your stomach acid. And I just didn't understand. I'm like, why wouldn't he want her to be on that? Like, she has reflux. This would help, blah, blah. So I did feel a little bit like, man, like So I just went to him and asked, and I learned so much. And I learned that because they were on an acid suppressant, that the formula actually wouldn't thicken. And I didn't know that at the time. And so I could have done damage if I like try to be a know-it-all, or if I'm like, I think I know best, I'm like, well, I think you should be on that, instead of like asking questions and learning something new.
Yeah, I think that's great. And that's, kind of goes into the things we talked about in the first episode about like calling people in versus calling people out. Like by calling in, you're asking.
Oh, I like that.
Yeah, call people in. So like you're asking questions. You're saying, I want to know about it from your point of view. Can you show me where I can learn more about what you're doing or how you're applying it? Or could you tell me why? Sometimes you find like, wow, actually that does make sense. And like, I now know why you're doing the thing you said, just like in the situation you just talked about. It's like, oh, cool. Thank you so much for explaining that. But if we go into it of like, I just don't think there's any possible reason why you're doing this. Like, what are you doing? Why would you not? If you approach it in a way that's more like in a defense position versus just like offering. Yeah, then I think that's kind of where that plays a role. And a lot of times if I'm in a difficult situation with like, maybe I'm providing feeding therapy and an OT is providing feeding, we're both doing it. A lot of times I'm opening up this discussion to say like, I want to make sure we have continuity of care. I want to make sure that what I'm doing overlaps with what your goals are. I would love to collaborate so that like we can both be targeting similar things, because feeding is a sensory motor experience. Like we need all aspects involved. And so, if you open it up of like, what are your goals? What are you doing? Here's what I'm seeing. And just like collaborate in that manner. A lot of times you can come to that same page of like, oh, here's what I was thinking. Here's why I was thinking that. Here's how I would maybe go about it.
And the same, it goes both ways, because if people ask a question, instead of being like defensive or judgmental of their question, like taking it as an opportunity to like teach something new is another one. And I think this is purely my opinion, but it's based on my observations and also just listening to different people speak on speech therapists as a whole. And I think a lot of times we're like very nice people, but it's harder to like, it's not necessarily always the most helpful thing to just be nice. We also have to like keep it real and be honest. And there's a way to do that kindly. But I think I think we run into trouble when we're either like being like playing nice and like not being real about something when it's an opportunity for someone to grow, or we're being defensive or judgmental.
Yes, no, absolutely. I agree. And I think like opening that up, and we don't like to, quote unquote, like rock the boat with stuff. We don't want to challenge that, but we really need to be comfortable with being, like you said at the beginning of this episode, like being comfortable with being uncomfortable, like recognizing that when you are uncomfortable, that is a moment of growth. Like that is when we grow and, can work through critical thinking, because critical thinking is hard and it's often uncomfortable. And so like just putting yourself in those positions and knowing like, okay, this feels a little bit weird, but the more I grow in this area, the more I learn about this area, the more I experience in this area, the better it's going to feel. And it's not always going to feel uncomfortable.
Yeah, that's important too. It does get easier.
Yes, it does.
And then there are other nights where I don't sleep, so I don't know.
Yeah, and then there's also that. And hashtag Lexapro.
Zoloft.
Yes, I love it. And there's also medications and therapy that I highly recommend. Okay, let's talk about some of like the barriers to working on critical thinking and some of the things that make this I don't even know if it's necessarily a barrier, but what makes it hard? We talked a little about some cognitive biases, and that definitely plays a role in it. And like I said, there's going to be an episode coming out that talks more specifically about those. But what are some of the other things just like day to day within our clinical practice that makes it hard for us to think critically?
I'm trying to think of what other people would say, because it's hard for me to answer that, because I'm so passionate about thinking critically that so there are other things that are hard for me, like being organized is hard for me. So I think it's more so what are you talking about, like if it doesn't come naturally, or like if someone says they don't have time, or?
Yeah, I'd say like probably kind of like a mix of it, but even like your personal reflection on some of the things, I think.
Things that have helped me think critically?
Yeah. So like what was something that, make it hard? I'm thinking about like, maybe a family or a physician wants like a quick fix, and you're like, that isn't necessarily going to happen, or always trying to have an answer to something, kind of going into that, like, I have to know everything. I'm supposed to be the expert, when in reality, that can cause you to take that shortcut, take that heuristic versus actually stopping and slowing down. Maybe that's what I'm thinking of. Like, what are some of those barriers to being able to slow down and think about it? Like, if we're in clinical practice, you're in a session, what are some of those pieces to it?
I mean, I think a big thing, it's not for me anymore because I have a private practice, so I can go at my own pace. But working in the hospital setting, you have productivity standards, you have a schedule you have to keep, and there's not going to be time blocked out for critical thinking. So I think that it does make it hard for sure. If I think about working in that setting, like asking a colleague if they can peek in, like asking if it's positioning, like asking PT, like, can you just peek in the last 5 minutes of my session, help me like troubleshoot this, or asking OT to come in and help me figure out like the best way to build up a utensil, or like, whatever it is. Another speech therapist, like get another set of eyes for that. I think it's super helpful, and that doesn't take too much time. I don't know. What are some other ways?
Yeah.
Like, it's extra. It is extra when you're in that situation and you have a high caseload.
Yeah, I was going to say, I think one of the biggest ones is time, whether you're in the hospital or the outpatient setting, or even like home health, if you have a set time you have to see a patient and you're expected to like have a solution during that amount of time, sometimes it doesn't happen right then and there. Like, sometimes you take in a lot of information and you're like, oh no, like my 30 minutes is up and now I want to like think about this later, and recognizing that it's okay to not have like a very quick, fast solution in the moment. And I think some of that is just that like reflection piece, right? Of being like, okay, I'm going to make a recommendation right now. I think I can, but I'm going to think about this a little bit more, or I need to read about this a little bit more. But the time barrier, like, I think is one of the biggest ones. Cause like, yeah, I'm not paid to go home and do the research on that, like,
well, that's where it comes in. Like, what's your motivation? I guess. I don't know. Everyone's motivation is different. And there are plenty of things that help me, but I don't know if other people would want to do them or not. Like, I'm happy to share them, but
like, no, I think that's a good point, is like that. Yeah. The motivation to want to look in all of those, and recognizing like that just staying where you're at is not critical thinking, because like your practice should evolve and change. And if it's not,
oh, sorry.
Yeah, I was just saying, you're not
on Wednesday at 2 and you're like, oh shit, like, I don't know what just happened there. I need to think about that. I'm not sure. But then you don't think about it. And then the next Wednesday comes and you're like, oh crap, what are we going to do? That's not, I mean, that happens. That's real life. But also, like, how can we prevent that from happening? Because that's not really serving the patient best.
Mm-hmm.
So I don't know. One thing that I really like to do is, you do this actually, where you post a case and you have to like think about it.
Yeah.
So I think that is such great practice for critical thinking. And there's tons of ones like that, even for swallow studies, like, what is it? Dysphagia case files, or UC dysphagia or something like that.
Yeah. I can't remember
Where you can like watch the MDS and you can try to figure out what's, and then you can read the captions and see what was actually going on, and kind of like test yourself that way. In class, I always start lectures with a case study, like, okay, here's like a brief synopsis of this case, and then now we're going to learn content to help you try to problem solve this. And now at the end of class, we're going to circle back to that case, and like, based on what you just learned, like what components do you see that are challenging, and what would you do in therapy? So that from the very beginning, it's not just about like memorization and knowledge, it's about application.
Yeah. No, for sure. And I think that's something that I like care very much about, is like not just providing information, but also like providing the reflection, helping with like, okay, now how do we apply it? Like, okay, you read the article, but what does that mean? What does that mean for practice? How does it apply like from a qualitative manner? Just because you have the stat doesn't mean it's going to carry over. And like, also, I think the difference between, this is like a whole soapbox I could have, but the difference between statistical significance and clinical significance, and recognizing like, just because something showed to be statistically significant in a super formalized study, how significant is it to your clinical practice? I'm thinking about, I know I briefly mentioned like the tube weaning kind of thing. Like,
Yeah.
statistically, like they weaned from their tube 1 day faster, but like clinically, how does this apply to me? And like, does that approach really matter? Does that 1 day,
And functionally.
yes, make the
Same with the
functional?
goals, like going back to what you were saying about goals, like
Mhm.
does it really matter if they like, I don't know. There's always these like random numbers that we have to put in goals. And it's like, what is this? Like, how can we make this more meaningful for families? Like, how can we make this more functional for our patients? Because sometimes I read goals and it's again, it's that autopilot, like, let me check a box, let me just, but yeah, we're not really measuring the progress of what that child actually.
Yeah, no, I think goals is a big one that we get into autopilot on. And I say we as in like I am I am
Yeah.
part of this. I'm not speaking for Tova, but like
Oh no. Yeah. No. Yeah.
it's a big one that you can get into autopilot with because it's just like, oh, let me just like put something in there and then we'll just move on. But like recognizing like how we write those goals can affect therapy because sometimes you get stuck in the like, oh, I have to target this goal exactly like that, or I can't measure it when it might not necessarily be exactly what the client needs anymore, or written in a way that like is like supportive of the functional skill you're trying to achieve, and
Yeah.
kind of honing in on that. Yeah. Yeah, for sure. Okay. So the last thing I would like to do is talking about a case and kind of walking through this process of taking a case and going through the process of like, how can you critically think through a lot of the different layers of it and sort of what that looks like. All right. So we're going to do the case now. We're going to walk through a case, but here's kind of the catch. And I'm not going to lie, my heart's a little beating fast because I'm a little nervous because Tova's going to present a case again based on real events, but she's going to change a lot of the identifying information. So, it's not going to be exactly the same, but I'm going to blind react to it. So I'm going to just say how I think about this case initially. Like, where would I consider going to start out? What are the things that I'm looking at? Because we're hoping that this kind of shows that like critical thinking can involve different layers of thinking, and it's not always like black and white, the exact same. I have no clue what this case is. I literally know nothing about it. So, all right, Tova, give me a history feeding status and
Okay.
I'll do
I'm
what I
happy to react blinds. Like you're not alone. So you can like throw it back at me.
Okay. We'll see.
I mean, I'm gonna be nervous, but we'll do
I
it.
know. I'm like, oh my gosh, I'm a little nervous about it. But like, you know what? Let's just do it. I'm gonna take notes as you tell me this case so that I can keep up with it. Okay.
I think that's a great example of like how you practice your critical thinking.
Yep.
Like it's impossible to remember all this stuff.
Yeah. First
So,
step, I'm gonna take notes. All right, go ahead.
okay. So little man is 3 years old. He has a rare genetic mutation that causes neurodevelopmental disability, motor planning challenges globally, low muscle tone. He has eosinophilic esophagitis with the only trigger at this point, dairy, cow's milk, and he has a laryngeal cleft that required a Prolarin injection. So it's just a filler to help fill that space when there's a cleft. Not for you, Brie, but if anyone's listening and they don't know what a laryngeal cleft is. And what else can I say about him? Oh, this is really important. So right before I started seeing him, which has only been a couple months, he started a trial drug that is supposed to like off brand, but supposed to improve, like help with muscle tone. And so prior to me meeting him, he used to drool a ton. He has pharyngeal phase dysphagia. He's on thickened liquid. Let's see, he's on moderately thick when I met him. And he also has a G tube to help with his nutrition and hydration. And he has had trouble gaining weight. He eats very small volume. And with the liquid being thickened, I think that also makes it less appealing and he doesn't take quite as much volume, but he's not drooling anymore. So when I met him at that first visit, mealtime was very stressful. Parents actually felt like they couldn't watch him when he was eating because if they looked at him, that he wouldn't want to eat and he didn't want to sit at the table. He liked to walk around and eat. And I think that's like all the big information, but you can ask like whatever I left out.
All right. So Here are some of my thoughts. However, I feel like I have a couple questions first. So that is definitely where my brain is initially going of like, I think I need more information. Okay, so does this child, are they followed by any other specialists or currently seeing any other therapies?
Yes.
Okay. Who?
So they're followed by GI and allergy,
Okay.
followed by neurology, OT, speech. What else?
Do they receive PT?
Off and on.
Okay. Okay. And then any like, do they see a dietitian for tube management or is that primarily with the GI?
Primarily with GI as part of like a team.
Okay. All right. Next question I have is when were they put on thickened liquids? Like how long ago was this? When did this happen? And then I also am curious when they got their G tube and like kind of like what was the reason that that was put in initially? So like when did it happen? Like what was going on at that time?
G tube happened at a year old. And what was your other question?
So why was the G2 put in? Like what was going on around that time frame that said, I mean, obviously we know there was probably like weight gain issues, but like did this, happen when solids were starting or like what kind of triggered that? And then my other question was when they were put on thickened liquids, when did that happen? And like why did they have an instrumental? How long have they been on thickened liquids for?
Mm-hmm. So he has had supplemental tube feeding for his whole life.
Okay.
But he did get a G tube placed early on. It probably was honestly in infancy, but I don't remember the exact age.
So did they have like a nasogastric tube for a little while and then the G tube was okay.
And then based on the results of, he's had multiple swallow studies. His most recent one was, I want to say it was last year, a little less than a year ago. And that's when he was placed on the diet that he's on now. But he had been on thickened liquids up until that point. They were just modifying and updating it.
Okay. So was placed on moderately thickened liquids at that time, but has always required some level of thickened liquids. Is that?
Yeah. The interesting thing to me is that when I read his swallow study, he did aspirate thin liquid, but when it came to thickening, his swallow on paper looked the same, regardless of how thick it was, but they did go pretty thick.
Okay. So on the swallow study, was there aspiration just at thin or was there aspiration at slightly mildly? There was all the way across.
There was aspiration at thin and slightly thick.
Okay.
And then I think based on the frequency of penetration with mildly thick, he was placed on moderately thick.
Okay. Another question that I have is with the, like up to this point, obviously we're 3 years old at this point and we've been having feeding difficulties since infancy. So have they been through any other feeding therapies? And if so, like, did the caregiver give you any insight on like what had been done, what was working, what wasn't working, like any information on that?
Yeah, he's followed by different teams, but never had feeding therapy.
Okay. All right.
Yeah.
That's so surprising to me. Okay. All right. So I'm going to give you some of my initial thoughts.
Okay.
So, excuse me. Initially, what I'm thinking about is that I want to get in touch with the rest of the child's team and just see what they've been doing, where they're at. Maybe I can't talk to all of them, but can the caregiver provide me like any records or testings that were done so that I can just, have that kind of all up to date. I would really like to know what OT is working on, especially since there is motor implications. And you had mentioned like global motor planning difficulties and low muscle tone. I'm just curious where we're at with that. Actually, that kind of brings up another question. What is the mobility status or the ambulatory status of this child?
He's mobile, he's walking, and I will say his muscle tone did improve. He's not drooling anymore, and his muscle tone did improve with this drug trial.
I was going to ask, did you feel like the medication was working? Okay.
I didn't know him before, but just based on
based on what parent report.
Yeah.
Okay.
Mm-hmm.
Is the child on any other medications?
I don't think he is. Maybe reflux meds.
Okay. reflux meds maybe, but not anything like there wasn't no seizure medications
No,
or
no, not any
okay.
medication.
Okay. Awesome. Okay. So that's very helpful because I'm thinking like positioning around meal times. I want to make sure that we have safety from there. From a sensory regulation standpoint, are there any like hyper or hyposensitivities across like any of the sensory domains?
He definitely has sensory preferences, but he's actually pretty open to like a variety of flavors and textures. And I think a lot of even the preferences that I see as I've gotten to know him more so come with him seeking the sensory input to help with the motor output versus like, yeah. Does that make sense? Yeah.
Yeah, no, that makes sense. Like kind of want stronger flavors or like bigger variation in temperature or texture just so that
yeah.
track where it is in our mouth from a motor standpoint. Okay. Okay.
He will eat frozen chicken nuggets.
Oh my goodness.
Like I've never met anybody who eats frozen chicken nuggets, and I thought it was so cool.
That's awesome. Honestly, it kind of makes me think about like we've normalized eating like cold pizza. Like, why can't we eat cold chicken?
Right. I don't know.
Pre-cooked. It's fine. That's so funny. Okay, that was going to be my other question was from a solid food status where what is the child currently taking in? I know you said like still having to supplement through the G tube, but are we, I mean, frozen chicken nuggets now, but at the time of evaluation.
Yeah, just like a few bites, a few times a day.
Okay.
Was mostly where we were at, but a variety of different foods.
Okay. Okay.
Yeah, different food groups, different textures.
Okay. From an oral motor standpoint, even though we weren't taking in a lot, did the child like, I know you mentioned low tone early on, but like how are oral motor skills just like functionally with those foods? Were there any that were more difficult than others?
Yeah, I mean, I think the more advanced texture we get, it's tricky. And you can see some reduced bolus formation, open mouth chewing, but functional, maybe sometimes swallowing a little too soon, like before the food's all the way chewed up. And I think sometimes too, like you mentioned, reaching out to OT. So when it comes to self-feeding, because that motor planning piece is already challenged, if we're putting too many things, like too many
Demands.
tasks for him. So yeah, so thinking about foods maybe that are easier to hold. So if we're trying to promote those oral motor skills, like working on one thing at a time, I guess. So even like working on cup drinking, I needed to help him hold the cup so that he could focus on what his mouth was doing. He didn't have that burden of like, how far should I tilt the cup and how far should I, too many things.
That's another thing I was going to ask. You had mentioned that the child was on moderately thickened liquids. And so I was going to ask, how are they taking those in? It sounds like maybe open cup is the primary.
Oh, so this is so interesting. And you would definitely like geek out with me over this. So when I met him, he was having it, and I think this is how the team had recommended it. They were doing thickened liquids using purees.
Oh, okay. Yeah.
And so at our second visit, we ITSE tested it, and he had coughed a few times with it. And it turns out that, like purees can get waterlogged, and also mixing, like it's really hard to mix it.
Not all purees are created equal. That's usually what I say.
Yeah. So when we syringe tested it, if you took up one syringe, it would have been considered mildly thick. If you took up another syringe, there was one that came out thin. It was like very inconsistent. And so we started using Simply Thick packets. So, well, I can talk about what we're doing with thickening if you want, or did you want to talk
Hold
about?
on, let me make my
make your prediction.
Yes, yeah. This is like, I feel like we're playing 20 questions. I'm like, just answer yes or no. Like,
this is what we do. Like in a visit, I'd be asking the parents all these questions.
So many questions. I have so many questions. Yeah, because I was gonna say, what are you thickening with? That was gonna be my next question. So it's primarily purees. Okay.
But we transitioned to Simply Thick.
Okay. Yeah. Well, so part of like my thinking about a child being on thickened liquids is the first thing I always do is test it with ITSE and say, where is it actually at? Because sometimes I find parents have been eyeballing it, or they were given a recipe for something, but they're starting to use other things. And so the recipe may not be perfect or might not be the same with every puree. So if they've been using that with applesauce and then they started using something else like a yogurt or whatever else, or not, in this case a non-dairy yogurt, if they started thickening with something like that, then it might not come out the same. So usually ITSE testing is where I start out to just get that baseline. However, I'm thinking about like with this child, is it possible, because they've never had any therapy to change their thickened status to do some like systematic weaning off of thickener. But to get there, we have to have a consistent thickness. And so thinking about like, all right, like as much as, we want to do some purees, I think we need something that's more consistent. And so going to a commercial thickener can really help with that because we get them to a baseline status. It's the same. We can make all liquids the same, no matter what they're drinking. And then we can wean it, because if we start weaning thickener and it's inconsistent, you're totally defeating the purpose of what you're trying to achieve. So that's one thing I'm thinking about with the fact that the child's on thickener. So, working on, and I also agree with, I know you kind of already hinted at this, but I agree with like not doing too many things at once. So I actually talked about this with some people on my mentorship call this morning about when you're weaning thickener, if you have a child that is taking liquids currently right now from a sippy cup or from a straw cup, and you're like, oh, but we also want to work on an open cup. It might not be the time to work on an open cup at the same time that you're doing that thickener weaning, because you're like throwing way too many things on them at once. So if you have a child on a sippy cup and you want them to drink from a straw cup, work on that skill, then wean the thickener, then you can slowly reduce it. But if you're changing a motor pattern from an oral standpoint at the same time as the pharyngeal standpoint, sometimes that's just like cognitive overload, and it can be really hard to really see changes there. So I think also recognizing that piece, but building on their independence with it. So I don't think you had said what cup specifically they were using for this. What were they using?
He does use a straw cup.
Okay, cool. So love that. I think though, choosing straw cups that have things that can support their motor ability. So I always want to promote competence within the child. So like, I want the child to feel capable of what they're doing. So maybe that means we put handles on it, depending on what he needs, or maybe we use like, I don't overestimate or underestimate the power of like a bent straw, like one that has, I'm showing this on the video if you're listening, but like a straw that has a bend in it so that the child doesn't have to like put their head over the straw, because
Right.
that motor pattern can be trickier. So slight modifications to support their independence with a cup that they are capable of using. So that's kind of what I'm thinking about from a thickened liquid standpoint. Also want to make sure we're implementing oral care. And honestly, like I would probably be doing some sterile water trials at the same time. I'm a big water trial person, but it depends. It just depends on where they're at with it and if they can tolerate it. So, if we are going to do any water trials, then making sure it's, sort of like a modified Fraser free water. So I'm not going to just like open end, like you can have as much water as you want, just like single sips, because kids don't do that. We have to recognize that, but working on the motor pattern, we ultimately want to achieve.
Some grown-ups also don't do that. I just want to say.
I know. Grown-ups
I don't follow the rules. So
no, it's so hard to follow the rules. But so again, that's going to be very family dependent. I haven't met this patient or their family. So it will depend on how I feel like if they can take it on. However, I would not do that until we have all these other pieces like managed, until IDSI's good to go. We're weaning the thickener. That's consistent. Things are going well. Then I would consider adding that in, because like if we want to swallow thin liquids, let's practice swallowing thin liquids, but we can do so in a safe and therapeutic manner. From the solid food standpoint, I think first of all, I love working with patients who are not super hesitant about certain textures or sensation pieces. It's like, oh, great. We can just put whatever. However, I think just paying attention to the small volume pieces and why is that going on? I would probably want to reflect a little bit on their current tube feed schedule, because if they're filling up on formula through their tube feed, that might be playing a role in why they're only eating a little bit at a time. However, if we play with that a little bit, of course, collaborating with the gastroenterologist on that schedule and recognizing okay, what do they need to take in? But if the gastroenterologist is cool with us being a little flexible on it and we're still seeing very low volume intake, I'd want to collaborate again with the GI and say, is there something going on from an emptying standpoint where we only want to take in a little bit of solids, or, whether that's at the esophageal or the stomach level, either one, because liquids like formulas will digest faster than some of those solid foods. So paying attention to that piece as well. All right. That's just kind of my blind react initial. That's where I'm stopping. I'm done, I think. I feel like I'm probably missing 100 things, but you know what? That's where we're starting because it's an ongoing process. That's what I'm telling myself. Your ongoing assessment always. So,
Ongoing assessment. Yeah, I
mhm.
love it. You hit on so many things that were important. So the first place that we started in therapy, and I should say, like, it's only been a handful of sessions. Like, this family is amazing, like so much smarter than me, and he's amazing.
That.
And he is also amazing. Like I'm in love with this little boy. But okay, so the first thing that we really did was to and when we talk about the why, I want to say too, and I know you are really good about this, like I'm thinking out loud with parents about like, here's why I'm suggesting something. What do you think? How is this going to work for you? What does mealtime look for you? Like, that's so huge because I could say all the things, but if it's not going to work for their life, it's like, who am I doing this for? So really talking about how to improve mealtime structure for him so that it wouldn't be so stressful for him and for his family. And also, so it could be something where he's like, you talked about positioning, where he's like participating and comfortable. And that happened really quickly. Like from session 1 to session 2, mom was like engaging, sitting with him. They were like chatting, and she had gotten this really cool footrest that I never saw that like inflates to like different heights. So freaking cool. And he loved it, and he felt like nice and secure. And so even from the outset, like just that alone, just having like regular mealtime opportunities, not grazing, sitting with his family and eating in a comfortable, supported position, he started to eat more volume. And so then at our second visit, he was throwing up with some of the bolus feeds. And so actually, like, I know you feel strongly about this, about like kind of like tube feeding on demand, right? So we talked about how like actually the biggest risks for aspiration pneumonia are aspirating your dirty saliva or aspirating puke. So if we think about that and we think about how like his tone is improved and he's not drooling anymore, but he's still throwing up. So they started to reduce that last bolus feed that he was always throwing up anyways. And we also started to do a thickener wean. And if we talk about implementation science, we were using the research out of Boston and using that systematic thickener wean. So we were adding an ounce of thin liquid and keeping the thickener the same. And I know there's different ways you can do it. That's just what was the easiest for the family and what would like fit in his cup. And I think honestly it's probably thicker than what he was having before when it was mixed with the puree. So we're trying to like navigate that now, but we started the thickener wean. And then when they started reducing that last tube feed of the day from that visit to the next visit, and there were 2 weeks in between each of these, he started eating a lot more volume. It's the first time that he had like a big jump in weight gain. And so we had one more visit, and then we met with the dietitian this morning, actually, like as a team, and they're going to be switching over, like from a hydration perspective, he still needs the support from his tube. And we're hoping that as we wean the thickener, it becomes more appealing for him to drink more. But for now, we're going to swap out at least the calories for that so that he can eat more volume and rely less on it from a nutrition perspective. Yeah.
Awesome. Yeah. I love it. Yeah. I feel like I appreciate that you shed more light on than I think I did justice for, just like mealtime routine and environment and like that aspect of it and how important just like that can be. I feel like I was talking definitely more from the like tube feed routine and mealtime like schedule, but also recognizing like not just the schedule, but like what happens at the meal, like who is doing what does that look like is another part to reflect on for sure.
Yeah. And it's all really important.
Yeah, that was a good one. I like that. Okay. Do you want one?
Yeah, get me.
Okay. All right. Hold on. Let me think.
Because I'm uncomfortable. So I have to do it. And it's okay if I'm wrong. It's okay.
It is. All right. It's your turn, Tova. Okay. So yeah, right. Okay. Blind react to this one. And just so everybody knows, like literally this is on the fly. Like I just had to think about a case and put it together. All right. So this is an infant, 2 months old, and was born full term, but has a diagnosis of trisomy 21, is on a G tube and is getting feeds through the G tube for like, they're dependent on that. However, caregiver is pumping and they are getting breast milk and then supplementing some of the feeds with formula for weight gain. So infants having some difficulty with weight gain. Caregiver really, really wants to breastfeed, highly motivated to breastfeed. Right now, they are trying it like once a day. And mom just reported like doesn't really latch ever. And if she does latch, it's for like a minute or not even a minute, like a moment, and then just is kind of done. And so she's attempting once a day, but that's kind of as far as they've gotten with it. But she's very motivated. They have not tried a bottle at all at this point. They did try for a little bit. The gastroenterologist kind of had them take away some of the tube feeds to see if like maybe she just wasn't latching because she wasn't hungry. However, she showed signs of hunger and was hungry, but could not get milk from the breast, and so started losing weight again, and so they put the tube feeds back up. So there you go. That's what I have for you. What thoughts and questions do you have?
How old is the baby now?
2 months old.
2 months old. Okay.
8 weeks. Like fresh 2 month, 8 week.
Fresh babe. And cardiac involvement?
No, actually, we do not have cardiac involvement. Good question though.
So why did she get a G tube right away?
Difficulty with feeds, was on the NG tube feeds. They attempted breastfeeding early on. It wasn't going well. And so they
never tried a bottle?
They tried, but it also didn't go well. And so this was a case where like, again, maybe did we need the G tube? Maybe we could have stuck with NG a little longer and gotten support, but no, they put a G tube in before they left the hospital.
And no other comorbidities like respiratory?
Mm-mm.
No, that's very unusual.
Yeah.
Feeding difficulties were that the baby wouldn't take in, having trouble latching and not taking in the volume.
Yep. Very, very weak suck. Would suck, but very weak, like just frequent unlatch, difficulty maintaining latch, and
So no diagnosed pharyngeal dysphagia?
No.
Okay. Yeah. So many things that I would want to see or try, I guess seeing why is it hard for the baby to latch? Like, is it purely that low muscle tone, or is she dysregulated? Does she need to be swaddled? Does she need rhythmic music or movement? Does she need that piece of it? Is she spending a lot of time in skin to skin? And then thinking about trying the bottle and seeing what that looks like for her. So will she take the bottle but she can't get anything out?
Yeah. So very discoordinated, even with the slowest flow nipple, just spillage everywhere. So not really working with the breast. When she would latch, it was okay.
But it was more so she couldn't get any liquid out.
Yeah. So, but just very, very weak, and then frequent unlatching. And mom's milk supply too, milk supply was good. Milk supply, she was doing really well with that and keeping up with pumping.
That's awesome. That's so much work.
So much work. Yeah, this mom was a rock star for sure.
Will the baby take a pacifier?
A little bit. She'll, again, kind of just short duration, but if you try to tug on it at all, very quick release, very, very weak suck.
Yeah. And is she on, with her tube feeding schedule, is it continuous bolus, pump?
It is bolus, and it's very consistently every 3 hours, even overnight.
Okay.
Overnight was continuous. I meant every 3 hours during the day. Overnight, they would get a continuous feed. And I apologize, it's been a while, but I want to say it was over 6 or 8 hours that the kind of overnight part was.
And is the baby showing hunger cues?
So when they did not really right now in that schedule, but when they tried to wean some of the tube feeds, she was showing hunger cues and was hungry. However, couldn't actually get the milk to
and neurological reflexes intact.
Is being seen by OT and PT as well. Developmentally, we have global developmental delay and low tone, but otherwise
so I'd be curious if we get her in that calm alert state, she's regulated, and it's just before a tube feed, and we'll do some skin to skin and maybe try a supplemental nursing system to help, since her challenge is the extraction piece. So if we can help her with that and she can also have that experience, I'd be curious to see how she'd do with that.
Yeah. Okay, you want to know kind of?
Yes.
Okay. No, you're like is very, very similar in thinking about how I was going through this. So one, my brain first went into, we've only been practicing breastfeeding one time a day. That's
True.
not enough opportunities for us to kind of learn this skill. But again, mom just hadn't received guidance on anything else. So she didn't know. She's like, we try it once a day. It's not going great, but
Right.
that's just where we're at. So one of the first things was just more frequently. So like you said, like before every tube feed, and I told her, I said, we want quality over length of time. So like if you put her to the breast and for 1 or 2 minutes, it's going very, very well. Great. If she shows like, okay, I think I'm done, then just stop. We want to keep it positive and keep that experience. However, before each of those, we talked a lot about increasing skin to skin, supporting that regulation piece. If she's fussy and moving and not, all over the place, we're not going to force into the breast. So we talked a lot about that piece. And honestly, like between that and doing some positioning change. So we ended up, because of, that lower tone that we're kind of working against, we talked about like, okay, let's try to make this a little bit easier for her. So we did like a reclined side lying position. So side lying, but also had mom lean back just a little bit. And once we increased that frequency in practice and supported that, like reading the cues early, supporting that, like, so if we think, again, implementation science, if we think about motor learning principles and neuroplasticity, like frequency, repetition is a big part of it. And she was able to wean off the tube and exclusively breastfeed. So yeah, it was like, it was so exciting. It was so amazing. But I will say I attribute this 95% of this to mom's dedication and commitment to that, because she was so motivated to work on that. And we had talked about, like, okay, like, we might introduce a bottle, we might try SNS, like, let's see how it goes. But the first approach was definitely like, let's just support her regulation. Let's read those cues and let's get enough practice. Cause right now, like her endurance, right? So she had like the range of motion in terms of like, she can latch and she can hold on for a moment, but her endurance wasn't there and the strength wasn't there to be able to like extract and do that over time. And so over time, she was able to build that skill, and it was like awesome. And then eventually we asked into doing the bottle then, and it was very similar in, okay, here is the bottle. She's a little discoordinated, but guess what? She just started trying it. So like, let's give her a little bit of time and kind of supporting that piece as well. And then same thing with solids. And then she, like, by a year old, she was just like on her way doing her thing.
I love that so much. And it highlights the fact that in both of the cases we talked about, we didn't explicitly say this, but a huge part of the therapeutic process was partnering with the parent and really like troubleshooting with them. Because like in my situation, like I can tell you what's ideal for positioning, but this mom was like, you explained it to me. I know why he needs this, and I'm going to find the right one that he'll like. And it wasn't one that I had ever seen before.
Right.
And
or like the one that works for like our space and our kitchen. And
yeah. And also the other piece of it is like, by including the parent, you also like empower them and you help build their confidence as a parent. So like this mom felt like, I can do this multiple times a day and it's okay. It might take a little while. And she's telling me like, I know now, she's telling me that she's done, or she's telling me that she needs a little help or whatever it is. And like, that is like, that's where the magic happens. It's so awesome.
It so is. And like, I feel like in both cases too, like having the focal point of the family and connection.
Yeah.
With the child, both had to happen in different aspects, but like that, you like will not go wrong if you focus on attachment and supporting that.
Yeah.
And then you can figure out all the other things, but like that, yeah, that should be a primary. So yeah. Oh, so fun. Those are good. Those are good to talk through. And of course, all of these have like different nuances and little bits that we did not go through, but like when you're thinking initially where your brain goes, and both of us both could draw on research and like what the empirical data shows in certain situations to help justify those decisions, and making sure that like critical thinking can help during sessions if you critically think it through with the family. So include the family in it, help them understand the why, like you were saying, Tova, like almost like narrating your thought process. So I want to try this because of XYZ. And it's like, as silly as it sounds, like that's critical thinking in the moment, because then the family can provide you feedback on
Yeah.
what works and what
I
doesn't.
have learned like some families, like I need to like dial it back a little bit because I don't want to overwhelm people with all of my thoughts. So sometimes I'm like, I'm just going to be quiet for a second and like think about this. So yeah, even that, like critically thinking, like, what does this family need right now? Like, how much can they handle me recommending or hearing, or, you know, even asking about history, thinking about like potentially triggering trauma, like past traumatic events. There's so much critical thinking that goes even to just navigating that relationship.
Yeah, and how you ask a question and open that up. And yeah, I think that's where like, you know, the open-endedness of stuff can be so helpful. And, you know, in a conversation I had with another colleague and talking about like, you know, asking questions like, what would, like when we're talking about like parent coaching, like what would maybe happen if you did this? Or like, how do you think that you could support your child in, you know, and being very just like open-ended at it. Like, I wonder what would happen if we tried this position. What do you think about that? And like helping parents to really like guide the therapy.
And also like having it come from an authentic place, because for real though, parents are the experts in their kids and they're going to know stuff that we would just never know. So for real, like it's not like when you say that, it's we do want them to feel empowered and involved, but it's also genuinely like, help me understand your child better, like what motivates them. And
yeah, I always tell families, I'm like, everything that I say is a suggestion. And if it doesn't work for you, I also need you to tell me that. Cause like, let me tell you, I am chock full of suggestions. I could come up with anything, but it does not matter what I say to you if it doesn't work for you. And being able to navigate that, because every single situation is different. And like I'm like literally be like, yo, Bree, cool. Thank you so much for that. Not going to work for me. And it's like, great. Now I can come up with something else that will work for you. And we can generate that together. Because if you don't give me that feedback and you're like, yeah, thank you. Cool. We're going to do that. And then it doesn't work. You don't do it because it's not going to work for you. We're not helping each other. And so also like opening that conversation up too.
yeah. Yeah. Or maybe it's like too stressful for a parent. Like it might be like a good move theoretically, like say it was like tube weaning and maybe like 20% for them is going to make them super stressed out. It's not worth it. Like we can go slower. We can do 10%. Like this wouldn't be my call. This would be, you know, working with the medical team and the dietitian, but just using that as an example of like, you know, it's not just about like the quote unquote right decision. It has to be the right decision for them.
Yeah, for sure. Because yeah, there's so many different approaches to it. So, or even like, you're like, you know, I think we're ready to start, you know, weaning this thickener. But if the family just does not quite have a hold on how to do IDSI testing, or they don't feel totally comfortable with like what we're working on yet, like that's what we have to support first. It's not that this approach or this therapy or this recommendation will never apply. It's just that maybe that doesn't apply right now. That's not what they need in this moment. And so it's not that like, oh, that's never going to happen. It's just, you might have to circle back when other things have been managed. So, but yeah, that involves a lot of critical thinking to get there.
I'm massaging my brain right now.
My brain hurts from this episode.
My brain hurts, but like in a really good way when you go to the gym, which I never do and I really should. But if I went to the gym and then you're sore the next day and you like feel good about soreness, like that's how my brain is right now.
Yes, that blind react was so fun. That was fun.
It's fun. It's so helpful. And it's also, I feel like you can always, as a clinician, I'll get like imposter syndrome. I'll feel like a fraud. I'll feel like, oh, if only I was like this person. And so it's, again, if I like stay in my own head, it's very dangerous. But if I'm talking with people like you and being like, okay, like, so you would have done the same thing too. Okay. Or like, oh, that makes sense why you would have done it a little differently. I should try that. But I'm not like stuck in my head. Like,
right.
It's a dangerous place.
Yeah. My head is very dangerous. Do not recommend going in there. Okay, well, Tova, thank you so much. I'm so excited for these to go out. I'm just so excited. Is there anything else you feel like we didn't cover or that you want to leave as just like a final mic drop on critical thinking?
No.
Perfect. I feel like we literally covered so many aspects of critical thinking. And, I feel like my biggest point or the biggest thing to take away, hopefully for everyone, is that like this is an ongoing process. It's not you go from not being a critical thinker to being a critical thinker. It's going to ebb and flow. This is a journey. And once you start progressing on that journey, there's going to be times that are harder than others. There's going to be challenges. There's going to be uncomfortable moments. But as long as you are actively engaging and recognizing ooh, I need to think a little harder about this, or I need to slow down to think about this, you're well on your way. So cool. Thank you so much, Tova. I appreciate you.
I appreciate you so much.
Thanks for tuning in to the Feeding Pod this week. If you enjoyed today's episode, please don't hesitate to share this podcast with your friends and colleagues and leave us a 5-star review wherever you're listening from. If you're interested in learning more about pediatric feeding and swallowing, be sure to follow Bree, me, on Instagram at Pediatric Feeding SLP. Or check out my website where you can get access to more courses and information, www.pediatricfeedingslp.com. Again, thanks for being here and listening to my ramblings, and I hope you'll keep listening. Until next time, cheers.